and it is to be understood by all of us that we can cure diabetes. A dream which was not possible till about 5 years ago. But with the advent of GLP-1 analogs, this dream of curing diabetes in a large majority of type 2 patients, not type 1, it is only type 2 patients, we can certainly tell him that yes, your disease can be cured. The word is cured, not controlled.
So talking about the main topic, that is remission of type 2 diabetes, just like to highlight the fact that now we do see in our routine OPD also that patients come to us directly. There are a lot of social media ads, there are a lot of advertisements which are coming up in the newspapers, Facebook, Instagram. We see a lot of apps are there which are claiming that even Ayurveda, homeopaths, all are claiming that we can cause reversal of diabetes. So is it a myth? Is it a fact? This is all we are going to discuss. Myself, I do see, and I would, even all of us might be seeing some patients which are coming to us directly and saying that I don't want pharmacotherapy. Do you have something that I can reverse my diabetes? I do such patients also that I don't want to add anything. My HbA1c is 30, but you do something and just reverse my diabetes. I'm not going to start the therapies. So what is it? So we'll talk about the scientific evidences about how we can, is it true that how we can remit diabetes or not? So first of all, if we just understand what is the concept of remission and why diabetes develop, it is mainly there is a personal tolerance for fat level. When it gets deposited in the liver and pancreas, when it gets exceeded, that is the time when type 2 diabetes develop. So this is a twin cycle hypothesis which I am going to discuss in detail also. So this is when the type 2 diabetes happens. Traditional concept was that type 2 diabetes is a chronic disease, irreversible illness, and it will require continuous addition and then continuous addition of pharmacotherapy, and ultimately 50% will be requiring insulin over 10 years. So this was the concept of type 2 diabetes. But now there is a concept of remission. How it came, we'll discuss that. First of all, diabetes remission, there is a definition which was given by John Lewis and co-worker, which was adopted by ADA also. So he has divided remission into two categories. One was partial remission, that is you are maintaining a A1C less than 6.5, fasting between 100 to 125 for at least 1 year, provided you are not on any pharmacological therapy. That is, that patient is not on even on metformin, any drugs which are for diabetes, plus he has not gone any anti-diabetic procedures, especially like bariatric surgeries. So without that, if he is able to maintain A1C less than 6.5, but for 1 year, it is partial. Complete could be when he can maintain A1C less than 6% or fasting plasma glucose less than 100. So this was the definition from 2009. Recently, 2021, ADA has cut down that 1 year to 3 months. And now this is just a consensus statement that if A1C is maintained to less than 6.5 for at least 3 months without requiring any drug, you can say that we have done a diabetes remission. So remission is now possible, but telling that cure, that is not possible. Why? Because ultimately one or the another time the diabetic people, once they undergo remission, they will relapse, rebound. Within 5 years, 8 years, they will rebound. So we cannot say that cure of diabetes can be done, which is generally claimed by advertisements, social media apps. So now this is a statement from Dr. Roy Taylor that remission in diabetes now challenges us that we should be looking beyond just treatment, and we should actually be transforming the health at its core. So don't look only for the pharmacotherapy, but also look for the metabolic parameters in diabetes and try to treat accordingly and try for remission. And in fact, ADA has also recommended, this is again a consensus statement where ADA recommends that type 2 diabetes patient should be considered for remission. But main question which arises with the concept of remission is, are the effect long lived? So generally what we see, the effects of remission, even if we obtain remission, the effects might not be long lived. Now coming to the main topic, what is the pathophysiology behind remission? This is from the twin cycle hypothesis by the Taylor, where it has been found that patient of type 2 diabetes generally is in a positive calorie balance, which ultimately increases the fat level in the body. This fat deposit at the liver, it will cause more insulin resistance, it will cause more insulin secretion, and this secretion per se will increase the deposition of fat in the liver. Sharad Chandra sir is here. I think you can, I believe sir, how many cases you see a fatty liver of type 2 diabetes? So there is a lot of incidence which is coming up. So if you can come in, sir. Yeah. So see how frequent it is. 90% of type 2 diabetics are having NAFLD, fatty livers. So this is all because initial stage is deposition of liver fat, and this liver fat increases the VLDL, and this VLDL actually goes into the pancreas and it gets deposited in the islet cell, and it increases the islet triglyceride. This islet triglyceride hampers the insulin secretion further, and you will see that there is a lesser insulin release and higher plasma glucose. This higher glucose lead to increase in the insulin secretion and further deposition of the liver fat, and this vicious cycle goes. So this cycle could be disrupted even if you reduce 5% of the weight. The islet cell will reduce, even if you reduce the islet cell triglyceride by 0.5 gram, you can disrupt this process and you can actually cause remission. So with this, you can, mainly by the weight loss, remission is possible by reducing the islet triglyceride and ultimately reducing the liver fat also. So remission is possible whenever there is a decrease in the liver fat, decrease in the VLDL export, decrease in the pancreatic fat, and ultimately improvement in the beta cell function. So coming, what are the things which can actually cause remission? Pharmacotherapy was first, which was shown to cause remission. Even this was when short-term intensive insulin therapy, we all know that A1C is more than 10. It is generally recommended that you start first with insulin. So what happened when they were given in short-term intensive insulin therapy? It has shown that actually patient might go on in remission. After 1 or 2 months of insulin, patient A1C is less than 6.5, some patient, and patient are not requiring only any drugs. So they might have gone into a temporary phase of remission. How much rate was seen? 46% at 1 year, which is not less, 42% at 2 years. So even there are trials which have shown that even drugs, if you are giving triple drug therapy on the starting when A1C is higher, you are giving metformin, glitazone, gliclazide, they can also actually get remission of type 2 diabetes, especially when type 2 diabetes duration is less than 2 years. Why is it so that you get remission? Because what happened in that if you are treating, the patient was going into the remission. So what happened in a mature beta cell, whenever there is glucotoxicity or a lipotoxicity, the beta cell become in a stress state. There is increased endoplasmic reticulum stress, inflammation in reactive oxygen species. So this stressed beta cell can either, if you are not treating it initially, the stressed beta cell can get trans-differentiated into different cell, alpha cell or delta cell. Or if you are or they can also get into apoptosis state. If you are treating it well, then they might get de-differentiated into a beta cell, and this will get activated, and hence remission is possible. So what happens is, whenever your patient is in a stressed state, you are treating it initially, patient beta cell might be de-differentiated and start secreting insulin, and you find that patient has gone into a remission for certain period of time. But multiple factors like genetic, environmental factors, patient might again relapse and rebound. So drugs like GLP-1 analogs, which sir was also saying that now these drugs have found stunning results to be a game changer in type 2 diabetes management. Drugs like tirzepatide, semaglutide now are approved not only type 2 diabetes but also in obese patients who are pre-diabetes or non-diabetic. They have shown dramatic weight reduction. But for reversal, there is no data available for GLP-1 because as we have seen for the definition that GLP-1 patient should not be on any therapy, and without therapy his A1C should be maintained to less than 6.5. Most of the studies are where GLP-1 was continued for 4 years, 5 years, patient was continued for a weight loss, his A1C has come down but patient was still on GLP-1. So there are no studies as such, but we do believe that stopping GLP-1 and maintaining the weight, patient might go into the remission. The main concept of surgical reversal and remission actually came from the bariatric surgery. There was wonderful result from one data you can see. This was from the initial stage of the life, that is obese adolescent who became type 2 diabetes. They underwent bypass surgery, RYGP bypass, where remission rate was 82% till 1 year and 99% after more than 5 years of surgery. So there was a dramatic improvement in remission rate. However, this was associated with unacceptable cost of high rate of abdominal reoperation as well as nutritional deficiency. So this was at this cost which was being seen in those patients. Similarly, Swedish obese subject, you can see remission was maintained till 72% at 2 years and 30% till 15 years. But still, you will see that even after bariatric surgery, average relapse would be that patient will go into type 2 diabetes after 8 years. So there is again a relapse which has been noticed with bariatric surgery. So with this concept, there came the landmark trial, and direct, if you talk about remission, this is the trial where all the concepts have been came from the direct trial. Direct trial author, what they thought that if you can achieve remission from bariatric surgery, why we can achieve? So there was a certain negative calorie balance after achieving after doing a bariatric surgery. There was a dramatic weight loss within 1 week, you will find, because there is a negative calorie balance patient is going on. Then there is a change in the gut microbiomes, plus multiple increase in the GLP-1 was also found after bariatric surgery. So why it is happening? There is a weight loss. So direct trial author thought that if we do weight loss, simple by diet, do we get remission? So what they did is they gave a very low calorie diet, medically supervised 800 calorie diet, and then reintroduce solid food later and assess the patient. One, it was the intervention group where low calorie diet was given. One was the control group where general normal diet which we give to the type 2 diabetic patient, they were given. And medicines were withdrawn. They were not on medicine, type 2 diabetic patient. So what it was found, there was a dramatic improvement. You can see that within 1 year, those patients who lose 10 kg, there was a remission rate of 57% in 1 year, which was maintained till 60% in after 2 years. Those who lose much higher weight, 15 kg, they remit by almost 86%, which was a huge number, and it was maintained till 70% till 2 years. So this was the trial where actually we thought that now losing weight can actually do wonders in remission of diabetes, and this could be prolonged at least till 2 years. So what happens is if you are replacing a meal replacement with a low calorie diet, there is a negative calorie balance which the patient body is undergoing, and you will find there is a depletion of liver as well as pancreas fat, and hence remission of diabetes. Similarly, this was a trial which was done before direct trial where look ahead trial. They have also shown that with weight loss there was a diabetic remission which was seen. There are some Indian trials also which have shown the similar result. Now coming with the most important thing about the diet, and now this is again a very debated topic, that which diet should be recommended to type 2 diabetes, how much weight loss could we achieve with which diet. In general, two diets are mainly recommended. One is low carbohydrate diet, where you are giving less carb, and one is low calorie diet. So what is the difference? If you say about low carbohydrate diet, it is you consume less than 130 grams per day of carbohydrate. Very low carbohydrate is when you are consuming less than 50 grams per day of carbohydrate. So if you are giving a very low carbohydrate diet, ultimately you have to increase your fat, and that become actually a ketogenic diet. So ketosis in the short term have shown a wonderful result. Mild ketosis has shown that it will reduce the inflammation, it can improve the inflammatory markers as well as improve the lipid profile. So mild ketogenic state have shown to be helpful, but how it will come in the long run, we don't have much data. So going for a low carb, high fat diet, increasing the ketotic state, long term we don't have data, but short term they are a good result. On the other hand, which I also prefer, is the low calorie diet, where you can just cut down 500 calories from the required calorie of the patient, or you can just give 1200 to 1500 kilocalorie diet plan to the patient. So this also have shown the similar result and have shown the similar weight loss. So if you just compare low carbohydrate diet versus low calorie diet, there has been found with both diets there improvement in the CV health. Weight loss in the range of 8 to 12% has been found with both the diets. Even remission rate was in the range of 40 to 50% with both the diets. So both diets are equal, both diets have data, both are appropriate. We can use either of the diets in our patient for if you want remission. Now another concept is eating strategy. How eating strategies can be changed for a patient. One could be portion control, just cut down the chapatis from 3 to 1, 3 to 2 or 5 to 3. So you have to control the portion. Then there was a religious fasting which is generally being carried out in our religions. Different religion, Muslim, Hindu, every religion have a fasting which are being found to be useful actually. Alternate day fasting is there. And next comes the concept of intermittent fasting. Intermittent fasting could be mainly divided into two, 16:8 or 5:2. 5:2 diet is 2 days you are on very low diet or 0 calories, like total fast. 2 days you are on either 500 calories, very low calorie diet, or you are not consuming only. 5 days you are taking normal diet. Next is 16:8, where 8 hours you are eating, but 16 hours you are not eating. So 12 to 6 you are, 12 to 8 you are eating, but rest of the time you are not, you are actually fasting. So this again has shown to have caused mild ketotic state and has been found to be much useful, and this has been found to be more prolonged and better as compared to high fat, low carb, high fat diet in the long run. So if I will just summarize that what are the therapeutic approaches for reversing type 2 diabetes. So one was the surgery which is actually not feasible for all of the patients. Gastric balloon, gastric band have shown lesser result, but bypass have shown good result. Dietary intervention, low calorie or low carb diet, both have shown good result, provided you give a cognitive behavior therapy also, because this diet need to be maintained for a long run. Next is the exercise. We should not forget that along with diet, exercise has to be included. Now resistance training has also been included in the management of type 2 diabetes. It's not only you can advise resistant training also. That has been found to be also been useful. Now there is one interesting thing. This is neuromuscular electrical stimulation. You can see this device, which is now being not much studied but has found good result. It is what it is doing. It is an electric stimulation which is consuming the calories, burning the calories. For 6 hours, if one is sitting on a TV, it can burn 2000 calories. So it is under way. It has been, devices are not, some devices are available, like an abdominal band is also available. So these are also on the way. Then pharmacotherapy, as we know that insulin therapy, especially if used initially, can give you a good result. Now, main thing is, if the patient asks to us that how we can am I a right candidate for remission, you have to look for a predictor of remission. So those patients whose diabetes duration is less than 2 years, then you can get a good result. Patient on insulin will less likely to get remitted. Patient whose glycemic control was not controlled since 2, 3 years, 4 years, and now he want remission might not be able to do because beta cells are already lost. Body fat status also determines. Low BMI patient, you might not get good results. Comorbidities patient or those with low C-peptide, you might not have good results. Even age and genetics play a role. So, just to highlight that diabetes remission is a journey and not a destination, because you might not be able to achieve and ultimately patient will rebound. So this is a reminder that with commitment, resilience and right support, we can actually shift the course of health and reclaim a life of possibility. So with this, I would just like to highlight this statement that if we are going and advising a patient with a good diet, exercise and patient going into remission, ultimately in the long run, patient will require lesser therapy, lesser complications will be there in the long run. So this can be taken as a journey in type 2 diabetes, and they all should be advised good dietary control, diet and exercise along with diabetes management. So just to highlight the major points, that type 2 diabetes was considered initially as an irreversible but now potentially reversible disease. So what is the definition for remission? A1C less than 6.5 measured at least 3 months without pharmacotherapy. It can be achieved by bariatric surgery, it can be achieved by diet, exercise as well as pharmacotherapy. Remission is generally durable provided you don't regain your weight. So it can be durable and can be prolonged. Predictors are mainly if there is a lesser diabetic duration, less than 2 years, patient on insulin, less fat, T patient, low C-peptide, more age, more strong family history, they might not get remitted. Thank you.
They say it's a duodenal mucosa, not the pancreas. It is the main culprit for diabetes. So there is what has been shown that patients who underwent bariatric surgery, the bypass, and the duodenal mucosa was not exposed, they had a rapid reversal of insulin resistance. So what they say is that now in gastroenterology there are a lot of studies, and even studies are going on even in India. What they do a term duodenal resurfacing. In that they burn the entire duodenal mucosa with some modality, and once they burn it, the mucosal healing occurs. So what happens is that there are certain neuroendocrine cells in the duodenal mucosa which are destroyed, and once the normal mucosa recur, they have found that these patients have a very good insulin response, all insulin resistance starts going down, and even the requirement of insulin, all these drugs goes down. So this is a new concept that might be that even when we go for a conference, these people say that might be we'll be treating diabetes. So you have to burn the duodenal mucosa and the patient improves. This is an early stage. It might have a role to play because there are a lot of hormones, this incretins, all these hormones, they have an interplay, ghrelin, all those things. So maybe in recent years this might be a modality. Endoscopically we can treat, at least we can control the level of diabetes.
Great.
Hyperglycemia because of relative or absolute deficiency of insulin, right? Accompanied with long-term complications which are merely vascular. Now this definition has not been changed whatsoever in the past 30 years. Whatever you are doing with duodenum or you're doing with, say, bariatric surgery, bariatric surgeons love to say that, oh, we can cure diabetes. But then the remission rate is very high. I know at least 5 people in Jhansi who went for the bariatric surgery, and after 10 years they are all on oral drugs. So it is not easy. Immediately, yes, within 2 years or 3 years, the diabetes is ameliorated. But gradually, you will see. And the basic culprit, what I find is that people don't change their lifestyle. If they are fond of rasgullas, if they are fond of sweets, if they are fond of fat, they continue to take it. And this is the biggest problem. आपने कहा ना कि हम remission कर सकते हैं weight loss से agreed, but then this weight loss creeps in, and in about 5 to 8 years' time, the same thing happens. So remission in diabetes is a very good concept. Unfortunately, 5 years down the line, we will find that most of them have reverted back to normal. Now the concept of insulin, this concept came about 25 years ago. I'm not sure whether you are aware of a doctor now, Dr. Sahai from Hyderabad. His son is now practicing diabetes. He was in 1998, 97 when we were just learning diabetes. So he came up with this concept that if we rest the pancreas, as soon as you develop type 2, remember this concept of reversion is only in type 2. Type 1 में तो कोई बात ही नहीं. So if we give insulin right from day 1, जैसे ही हमने detect किया insulin, so this will lead to a resting of the beta cells and probably the damage that is occurring will be reduced. And he did show a large number of patients in which remission occurred. But again, unfortunate part was that another 2 years time, 3 years time, most of these patients reverted back to type 2 diabetes.
उसमें नहीं होती है. अगर हम साइंटिफिक तरीके अगर अपने टेस्ट वर्ड्स को ऐसी रिसर्च करें कि टेस्ट वर्ड्स हमारे इस तरह से डेवलप हो जाए कि हम वो चीज़ को एडॉप्ट कर सकें और इस तरह से अल्टीमेटली.
Just a minute. मैं आपकी बात को अभी आप समझिए. What is the incidence of type 2 diabetes in India? It's about 10%. So, do you want to disrupt the taste buds of the remaining 90% who will never develop diabetes? What you are trying to say? आप क्या कहना चाहते हो भाई? क्या 90% लोगों को जबरदस्ती हम उनकी जबान को घिसेंगे कि भाई तेरी टेस्ट बड्स को हम डिस्ट्रॉय करेंगे?
Sir, but एक चीज है कि obesity is not about taste bud. It is also about a hormonal role play. Ghrelin, GLP-1, CCK, gut hormones, all are playing.
कोविड में लोगों का टेस्ट चला गया था खाने की
So taste buds.
देखिए ओबेसिटी अगर हम ओबेसिटी की बात करें तो ओबेसिटी
पुनः एक बार शानदार ताली से अभिनंदन. This is the last talk of our medicine update. And if Dr. Satish Agarwal sir was to accompany.
यार सामने देखिए सर. थैंक यू. यस आ जाइए मैम.
Navneet sir.
थैंक यू. यस यहाँ देखिए सर. ठीक सर. यस.
वो कहते हैं कि मंजिल के आगे
यस यहाँ देखिए मैम. ठीक. जी सर. यस यहाँ देखिए. थैंक यू.